of opioid overdose. Does everybody know what harm reduction or risk reduction is? I realize I don't know how you can answer my question, but basically what we're looking at is even when you can't cure a problem, there are ways you can sometimes limit the risks. So with something like the opioid epidemic that we have, we may not be able to get everybody completely off opioids. That may not be realistic, but we may be able to at least reduce the risk of overdose deaths. And that's what we're going to be looking at today, because I think that probably touches on everybody's practices. So I am looking at and I have no disclosures. I don't know if that got updated. You know what, let's work with your slides. Can you, I'm sorry, let me try to do that again, and I'll get with the program. Let's see if we can do that. Okay. So, yeah, so we're basically what I'm hoping we can come away with today is knowing what is risk reduction or harm reduction, who may be at risk, specific evidence-based harm reduction interventions for opioid use disorders, and how to incorporate overdose prevention into primary care practice in particular. And let's go to the next slide. Okay, so we're talking about taking precautionary measures to reduce the likelihood of a loss or to reduce the severity of a loss. So things like a security system at your house or business can help to minimize break-ins, minimize theft. Seat belts, airbags that we put into cars are another example of how we can reduce. They're not going to limit the number of crashes necessarily, but they might reduce severity of loss or injury. And there's certainly evidence in the car industry that, and it says here that in 2015, 9 car models recorded driver death rates of 0, and they attributed this to those safety features. Those of us who live in Taos County, New Mexico, don't have the recent cars that have all of these features, but okay, I'll have the next slide. Thank you. So, getting back to the principles of risk reduction, some people just aren't going to be ready or willing or able to stop using. And honestly, I don't know that we have the treatment available yet for the number of people who really need it. So what can we do to reduce the risk, to reduce the deaths that are happening? There have been approaches that have been developed to reduce the most harmful aspects of the drug use. And then the quote here, as you can see, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use substances. Okay, let's move on to the next slide, please. Some of the strategies, reducing the stigma and the prejudice around the problem. If somebody is addicted to IV injected heroin, we can supply needles, clean needles and syringes for them in the exchanges that you see somewhere. It's not, in my mind, it's not going to help us much to throw them in jail. We can increase the access to treatment. And we do have good evidence-based treatment for opioid dependence. We can teach safer injection practices and safer use. As mentioned here, don't use alone. Know your dealer. Use a test shot. And sterile technique. Some of that can make a lot of difference. I'm sure in primary care, you've probably seen the infections that can result from needle use. Places for safer injection. I know that Portugal, I believe, really turned things around by just providing safer places for people to use. That was one of the things that they did. Increased access to naloxone for overdose prevention. I know New Mexico has been really at the forefront of making sure that naloxone is available. One of the things I will mention a little later is that with the fentanyl scourge that we have now, that naloxone may not be quite as effective, but we can talk more about that. Let's go to the next one. So I'm not sure how up to the minute this slide is. 46 people a day dying from prescription opioid overdose, and I think 91 a day. I think for 2016 or 17, it was around 90 something per day dying of opioid related use. And that could be in combination with other things, but I believe that was the overdose deaths that we know of, that where there was heroin or another opioid in the picture. And I believe that translated to, I'd have to do the math, but it was something like 64,000 deaths last year. It's pretty astonishing and terrifying, really. So let's, I think we may have another slide on age group, but you can see on this one that there's a big spike at the 45 to 54 range. And what we're seeing, and what I was seeing in the most recent CDC reports, is that the two age groups that are growing at the fastest rate as far as opioid overdose deaths is the age groups of 45 to 54 and 55 to 64. I think the 55 to 64 group is growing faster than any other group, but that the 45 to 54 remains on top. You know, and I think we need to kind of wrap our heads around that when we see patients in those age groups, the people you wouldn't necessarily expect. I think we think of the heroin trade as mostly targeting the young people. But I think what we're seeing in this older adult group is that most of them are probably starting with pain medications, the prescribed pain medications. So let's move on to the next one. Okay, so risk factors in overdose. More than 100 milligrams of oral morphine equivalents daily. So that looks like that was a 2013 study, and there were other studies behind it that showed that once you get into those ranges of daily use, that's where you're starting to get closer to that lethal dose. This is a big one that I see a lot, is the recent release from a controlled environment. So somebody who comes out of incarceration or treatment, you know, where they've not had access to their pills or their heroin, whether they've gone through withdrawal the hard way, or whether they've had Suboxone or methadone or anything to help them. Once they're out there on their own, their tolerance is lower and they're at really high risk. And if they're not getting the kind of outpatient follow-on treatment, you know, whether it's IOP or something else, they're at very high risk. And that's really worth knowing. You know, a lot of times people come out and they think they can go right back to the same dose of heroin that they were taking before they went in, and that's when you see people dying. They've lost that tolerance. Same thing after release from emergency care for an overdose. Again, if you don't have the follow-on treatment to really kind of support them, it's very, very high risk. Okay, mixing opioids with benzos, alcohol, other drugs, anything that's going to be a central nervous system suppressant. Muscle relaxers, soma in particular can be nasty. That one gets metabolized to meprobamate. Isn't it meprobamate? I believe it gets metabolized to, has a long half-life. so you want to be careful with what if you have patients on prescribed opioids, please make sure they understand the risks, and please know the risks of what else you're prescribing or other doctors are prescribing. And then any of the medical conditions that are going to diminish their capacity for metabolizing renal, hepatic, pulmonary diseases, HIV. Let's move on, please. So I found this one really interesting, that where people are getting the pain pills for non-medical use. So this is 2010. It's probably still the case, only more so. Most people, the large majority, at least 55%, are getting the pills free from a friend or relative. And so they're not usually buying it initially. 80% of that group, those pills originally came from a prescription from one doctor. So your classic scenario is, grandma's pills are in the medicine cabinet. She was given a 30-day supply, but she really only needed 3 days. And so the pills are just sitting there waiting for another time she might need them. And, the teenager comes along and finds them. And that's a very classic way that somebody who wasn't prescribed them in the first place can start. Let's move on. So abuse deterrent and resistant formulations. So there have been a lot of things that have been tried. We know that over the years, the Percocets and Vicodins and the oxycodone and hydrocodone preparations have been combined with acetaminophen. And the idea originally was that it would be a deterrent for people to not overuse it, because we know that the acetaminophen is toxic to the liver. But I think we all know that that really didn't work. And what we have now is we have a lot of people addicted to opioids who also have liver disease, which just compounds the problem. So that's been a serious issue. Other things, there really are no proven abuse deterrent or resistant opioids or formulations. Buprenorphine combined with, thank you, that puts in the various things. So yeah, they've tried a lot of things with the physical barriers, the agonist-antagonist combinations. So something like Suboxone that combines the buprenorphine, which is a partial agonist, and the naloxone, which is an antagonist. I've had just as much success with the plain buprenorphine. I don't know that the Suboxone combination really makes that much of a difference in terms of effectiveness. Aversive components, I think the acetaminophen is supposed to be an aversive component, but again, I think people who really are stuck in that cycle of addiction are not thinking down the road to what happens with their liver down the road. Prodrugs, I'm not sure what's in the pipeline in terms of prodrugs that have to be metabolized to actually create the opioid in the system. Various routes of administration, so something like prescribed fentanyl is used as a patch, and it's not an oral formulation. Again, buprenorphine is taken under the tongue and not swallowed, and is not particularly effective. The naloxone, the blocker, is put in basically so that if people inject it, the antagonist will have an effect and they can go into withdrawal. So that can be somewhat aversive. I think it is to a small degree, not so much. Again, nothing proven. Let's move on. So changes in use secondary to supply and demand. So things like the prescription monitoring programs, which are available in most states and required in, I believe, a majority, are helping. So there's some reduction, and I think physicians with education around that as well are getting more savvy. But it doesn't really address the issue of people who are already in that vicious cycle of addiction. And so what we're getting, unfortunately, is more people shifting to heroin. You know, if you've been started on whether it's oxycodone or OxyContin, which was a big one in the 90s and still is, you know, and then your doctor used to prescribe it regularly, but is now kind of listening to, you know, concerns and has gotten concerned about it. What I've seen is a lot of doctors were told, okay, no, this clinic's no longer treating pain. This practice is no longer treating pain. And so doctors who are treating their patients, doctors, nurse practitioners, other providers, have been treating patients for pain. They're suddenly told by their practice that they can't do it anymore. And they're kind of forced the patient is forced to either withdraw suddenly, or, you know, they're referred to a pain specialist, say, but there aren't enough pain specialists to go around. So I think what we tend to see in psychiatry and addiction medicine is we see people who go to heroin. It's available, it's cheap, and it works. And whether they're getting high from it or not, it deals with the problem. It keeps them out of withdrawal. Let's see. So yeah, and we're seeing too a rise in the injection drug use, again, usually heroin. And more of I think this may also contribute to the demographics of the 45 to 65 year old age group, more people moving over to heroin. You know, as we all get scared and cut back on the opioid prescriptions, we're seeing more people moving over to the injected heroin and dying. So definitely there's still issues with accessibility to treatment. You know, we definitely have some stuff to work on. So I mean, that's what this is about, is trying to teach people out in the trenches of primary care to be able to treat addiction. I have my feeling is, and I've said this to people, that to me, anybody who is licensed to prescribe an opioid pain medication ought to be required to take the training and be able to prescribe buprenorphine to help people get off of that medication. So to me, it's not just referring somebody to a psychiatrist, and it shouldn't necessarily be referring somebody to a psychiatrist or addiction specialist. I really think that anybody who treats pain in any way with opioids really ought to be able to help people with the addiction side of it, because most people do become dependent to some degree on the opioids, and they shouldn't be stigmatized, and they shouldn't have to be siloed into the behavioral health world. We should all be working together on that. So that's my 2 cents there. Whoops, I did something. I just lost my screen. Wait a minute here. Can you still hear me?
Yes, we can.
Okay. I somehow lost my screen with the slides, so I'm not sure what I did here.
Can you see the current?
I got it.
Okay, great.
Sorry about that. Okay, so let's see, what page? Okay, we need to go to the next page. Okay, so yeah, CDC statistics 1999 to 2013, U.S. drug poisoning deaths. So this shows you, basically, it's showing us heroin in red, and you see a sharp rise since 2010. that number continues to go up. I can tell you for sure in the last 5 years that that number continues a steep increase. We're seeing other opiates, and I think they're talking about morphine and codeine and, you know, the non-synthetic opiates there. And those are coming down a little bit, and I believe those continue to come down a little bit. Methadone, I'm not sure what's happening. It obviously started to decrease as of 2013, and I'm not sure what that trend is at this point. And then the other synthetic opioids, the oxycodones, and they have those flatline, but I think in the last 5 years, if you add in fentanyl, which is a synthetic opioid, you would see a very steep incline in the last 5 years with fentanyl. That's a scary one, and we can get into that a little bit more later. So let's move on to the next slide. Okay, so this is also CDC data, and it's looking at law enforcement encounters. Okay, talking about fentanyl, testing positive for fentanyl between 2010 and 2015. And look at that steep incline. Really, it started in 2013. I'm not sure exactly what the gating event was that just flooded fentanyl in the marketplace. But we're definitely seeing more fentanyl, and then carfentanil. So fentanyl is, I believe, 100 times stronger, more potent than heroin. Carfentanil is, I believe, another 2 orders of magnitude more powerful than that. So that's getting into scary. You know, with carfentanil, even the emergency workers are at risk if they touch it. So, you know, what we do with that, I don't know, that's a whole nother discussion. Let's move on to the next slide. Okay, so in terms of the age-adjusted death rates for 3 causes of injury, so we're looking at motor vehicle is the red one on top. That one's coming down. You know, they have some good measures happening in cars. We don't see as many people dying on the roads. Firearms, you know, aside from what we see with some of the major shootings, the actual numbers of death rates due to guns is actually declining a little bit. But look at the bottom line. That's becoming the top line, drug poisoning. And that's as of 2013, and really 5 years ago, that one keeps going up. So let's move on. So mandatory use of the PMP, pharmacy management profiles. I think that's what the PMP is. So New Mexico, Arizona, Colorado, they're all in, I believe, the mandatory. I think the orange here is mandatory use of the PMP. I know here in New Mexico and in Arizona both, and in Colorado, we're required to be using the PMP. There are various ways that gets enforced with licensure. And it looks like this swath of orange states here, similar thing. We still have a lot of states where it's not required. You know, I'm just looking at this map now, and I'm glad to see that states like West Virginia and Ohio and Kentucky, where the opioid epidemic has been just horrendous, are among the required states, but New Hampshire's been hit really hard, and it looks like they're not among the required states. But maybe since January of 2016, maybe that's changed. I don't know. That's a question in my mind, and maybe I'll check that out. Let's move on. So, and in primary care in particular, you're going to be seeing so much of this, and what can you do to address the problem, particularly of the overdoses with opioids. So there are some CDC guidelines. This gives you the link for the CDC guidelines, and then this is kind of a summary of those guidelines. So the three main principles are: use non-opioid therapies, start low, go slow, and close follow-up. So as far as the non-opioid therapies, you want to, do what you can with non-pharmacologic therapies and non-opioid pharmacologic therapies. I saw something recently, a study, I can't tell you where I saw it, where it looked like opioids didn't do any better than non-opioids in terms of treating chronic pain. So I'd really look at starting with other things. Figure out what your parameters are for measuring, what are your goals of treatment? How are you going to measure the outcome? And really work with the patient on how to, is it really helping? And as I said, don't use opioids routinely to treat chronic pain. If you do, make sure you have a very clear sense of working with the patient and measuring whether it's in some way of whether it's really effective. Start low, go slow. So you want to, if you do need the opioids, you want to start with the lowest possible effective dose, as we tend to do with most things. Start with the short acting rather than the long acting. My thought about this is, you get a better sense of what works. I don't treat pain, but with anything like that, I like to really get that feedback from patients. And certainly if I'm using buprenorphine, I really want to know exactly what the patient is experiencing. So if you're starting with a short acting, hydrocodone, oxycodone, work with the patient, have them chart it, have them, get a sense of, how long does it take to be effective? What does it do? How much does it ameliorate their pain? How long does it last? What happens when it wears off? Only prescribe the amount needed for the expected duration of the pain. How many times have we seen people get a 30-day supply of pain medicine from a dentist after a tooth extraction? That doesn't make any sense. And I think that's changing some now, but I think we can all look at that. Most acute injuries do not require a 30-day prescription for opioids. Taper and discontinue if there's no improvement or if the risk of harm outweighs benefits. Close follow-up, so you want to be following the PMP, you want to do urine drug tests, and this should all be spelled out at the outset. I recommend having a contract with the patient so they really know what's required of them. Really try to avoid the concurrent benzos and opioids. We all know that one. And refer for treatment. If you think they have an opioid use disorder, try to refer for treatment or get the training yourself to do that work. Let's move on. SAMHSA has an opioid overdose prevention toolkit. So that can be useful as well. And I think the link is on here somewhere, if you can see that. It may be in a follow-up slide. Let's see what's next. Okay, so they have these 5 strategies basically. So strategy 1, encourage providers, people at high risk, family members and others to learn how to prevent and manage opioid overdose. So that's going to include identifying it, knowing what to do, hopefully having on hand some naloxone and how to use it. Ensure access to treatment for individuals who are misusing or addicted to opioids or have other substance use disorders. Yes, obviously, that's a good idea. We want to have all of that available. Ensure ready access to naloxone, okay? And then people need to be trained in how to use it. Encourage the public to call 911. Someone's in an opioid overdose, they need immediate medical attention. Know, by the way, that naloxone has a very short effective life. It does not last very long. It often doesn't last more than 45 minutes. So, you know, in some rural areas, that's not even going to get them through the ambulance ride to the hospital. So, so know that they may need multiple doses, especially with something like fentanyl that lasts a long time and is extremely potent. They need multiple doses. Encourage prescribers to use state prescription. Okay, yeah, the PMP programs for sure. Let's move on. Okay, preventing, recognizing, managing opioid overdose, what an overdose looks like. Okay, blue lips, blue fingertips, small pupils, pale skin, shallow or labored breathing, non-responsive to voice or sternal rub. And, you know, obviously there are going to be warning signs before that, before the person is on the bed or on the floor non-responsive. You know, they might be confused, they might be dizzy, they might be falling down, they might be nodding off. You know, so there are things that can come before, you can be watching carefully. Reversing an overdose, you want to assess the scene for safety, yeah. Assess the person, call 911, do rescue breathing if you need to, and administer the naloxone. Do call 911 first because you want to get them on the way, especially in rural areas. It can take time and those minutes really, really matter. Okay, next. Okay, so on strategy 2, so that was about recognizing it. Strategy 2, ensuring the access to treatment. So yeah, effective treatment can certainly reduce the risk of overdose and help people attain a healthier life. I have seen people turn their lives around. It is the most rewarding thing I think I've done in medicine, is really helping people turn around their opioid dependence. And it also turns around everything for their families. So yeah, reduced infections, reduce criminality, improve self-care, social functioning, provide or know where to refer for treatment. So yeah, methadone or buprenorphine are the 2 main opioid treatment programs. I won't get into those in detail now. In office-based treatment, buprenorphine and naltrexone, I really encourage everybody who prescribes, get yourself trained in working with buprenorphine. It's not that hard. And it's not that scary. It's way less scary than the potential for overdoses. So I really highly encourage that. We need more people doing that. Counseling and other supportive services. We all know that a drug isn't going to turn around somebody's addiction. So people really need, a patient really needs that support. They really need the counseling. They really need to, you know, an underlying addiction, we all know there's always trauma. There are always issues. There are other life issues. So you really need the wraparound treatment. So yeah, you can state health department, alcohol and drug agency, SAMHSA, there are all kinds of resources. And I think a lot of them are listed here. They may be listed more at the end, I'm not sure. Let's move on. We're probably running low on, how much time do I have? Anyway, whatever, we'll keep moving through.
Sorry, we just couldn't unmute, but we are hoping for someone to have some ad hoc or follow-up cases, but you are otherwise not in a rush because we didn't have any formally
Okay.
cases. However, let me make that a call while she's finishing. If anyone is interested in giving us a follow-up of someone we've already heard about, or just has someone on the fly that they're interested in asking about or telling us about, we'd be happy to hear that. So otherwise, thank you for taking your time.
All right, and I might be able to come up with something. Okay, thank you. All right, so strategy 3 in the toolkit, ensure ready access to naloxone. So naloxone is an opioid antagonist. It has a high affinity for the mu opioid receptor, which is the same receptor that the opioids all bind to, but it displaces the other opioids from the receptor. So it will outcompete heroin, oxycodone, any of the other opioids. It will outcompete them. It's powerful affinity. It will also prevent the other opioids from binding. It does work within minutes. It's like magic. So it lasts 20 to 90 minutes, and it is FDA approved for IV, subcutaneous, IM, and intranasal use. And overdose deaths can be prevented when naloxone is administered. However, one thing that you never hear about is that when naloxone is administered to somebody who's in an opioid overdose, it's what's going to happen when you suddenly replace all of those heroin or oxycodone molecules, from the opioid receptors. What's going to happen? Your person's going to go into acute withdrawal. So that's one of the reasons you want to make sure that you're securing your environment and making sure it's a safe environment. People freak out when they go in, just when they come out of this blissful sleep that they're in, this near-death state that they're in, and you're suddenly yanking them out with painful withdrawal. They're going to be pissed. Be aware of that. People get really angry sometimes when you save their life that way. So let's move on. But it does save their life, and they'll later thank you, hopefully. Okay, so prescriptions for nasal naloxone. Naloxone HCl, it's 1 milligram per mil. They come in the 2 mil pre-filled syringes, and I believe you get 2 of them in a kit. So 2 doses. And so it looks like you can get it as that's a needleless syringe. And it gets squirted up the nose, and you can get brief training on this, and if you have a nurse in your clinic who can get trained up on this, it's a good idea to make sure that anyone who is being prescribed opioids, or anyone that you think might have an opioid issue, and we all miss them, but it's a good idea to prescribe them the kit, and and also if you can bring in family members to get trained in using it, because obviously the person who overdoses is not going to be the one who's using it. So you really want to make sure that you have family members, friends, whatever, somebody who comes in that one time with the patient to get trained in using the kits. I know some clinics actually have the kits on hand and can dispense them directly, and I'm not sure how that works. I know now you can get them from pharmacies as well, and I know Medicaid does cover them. So let's see, there's a high concentration naloxone product, the 4 milligram per 0.1, designed for, okay. So this reduces the amount of fluid insufflated into the nose, allowing for greater retention. So I don't know, I'm not in the trenches with this, and I don't know offhand whether the higher concentration naloxone is being preferred at this point, or how much that's being used. Is there anybody who knows? Wants to pipe in on that? Any experience with that? And I'm thinking that high concentration one really should be looked at, if it isn't already being used, for suspected fentanyl overdoses. That might be much more effective. So, okay, let's move on. So what you can do in the office setting, provide patient-centered care. It's all about the patient, and it's really never really one size fits all. I always like to kind of gauge where my patient is at, and kind of get in that same space with them, at whatever level they're able to understand or handle. Let's get at that level and talk about it, and figure out, what they want, what they think they want, what they don't think they want. Consider medication treatment for any patient with an opioid use disorder. So I'm thinking, you want to, if you're not equipped yourself to work with treatment for an opioid use disorder, please refer them to someone who is equipped to do that if the patient is willing. Okay, so unconventional treatment sites. I'm not sure. This wasn't my slide. I'm not sure what that's suggesting, but if a person is open to or prefers something outside of mainstream medicine, there's some research happening now with MDMA and addictions. I know Ibogaine is used in Mexico. I don't think it's used yet in this country. So I would be open to talking with patients about what they might want to do and what they have the resources for. Certainly, insurances aren't going to cover most of the unconventional treatments. Addiction counseling, for sure. Again, there's no drug you can prescribe that's really going to treat somebody's addiction. It doesn't work that way. People are way more complicated than that. So flexible treatment goals and desired outcomes. So again, back to that idea of, what does your patient want? How motivated is the patient? At what stage are they? Do they even recognize that they have an addictive issue or a problem? And, if they can't see that they have the problem, then you really want to work with just the harm reduction, and make sure they have the naloxone and somebody trained on that, and, that they understand the risk of overdose. But if they're motivated and they can see that there's a problem, then you can move further into treatment and work with them yourself or refer them on. Collaborative relationships. So make sure you know who's available, what's out there. Is there a methadone program? Are there inpatient detox programs? Is there, what do you have for inpatient, outpatient? Make sure you know what's there so you can work together. And also, I would really, really, really emphasize that what I see around the state of New Mexico in particular is that there are inpatient programs that are not well coordinated with outpatient follow-up, and vice versa. And ideally what we really need is, let's use the inpatient programs as that safety net, but if you don't have the trapeze for your Trapeze Act, why do you have a safety net? I think we really, really need to be amping up what we do on the outpatient basis. It's more cost effective, and it really deals with the person where they live. Remember, when people come out of an inpatient setting, they're at high risk, both because they've lost their tolerance and also because they've been in a controlled environment and they haven't had to manage their environment all by themselves. So, when somebody comes out of a detox program or even a longer rehab program, they still need the support in getting back into their lives, because that's when they're at highest risk. And I really feel like that's where we really need to focus a lot of our attention. And as in primary care in particular, you may be the one who sees that person first, after a hospitalization for detox or rehab or whatever. And just be aware that they might not be plugged into the system that they need. So it would be really helpful to know what may be out there that they're not tapping into. So integrating primary and behavioral health, right, using a harm reduction approach. Yeah, we've been siloed for too long. We all need to work together. There are various models of bringing behavioral health into the primary care offices and also bringing primary care into the behavioral health offices. I've seen both. There are a lot of ways of doing it. I think we all need to be thinking a little outside the box if it's not already happening where we are, but we really need to work together. These are, we share patients and we really need to look at them as, whole human beings and not just, you know, the diabetes side or the schizophrenia side or, you know, whatever. These are whole human beings we're dealing with. Recovery-oriented support services, peer mentoring, group therapy, social services. Again, I can't emphasize that enough, how important the support is in particularly on that outpatient basis, especially when they're just coming from the acute setting. They really, really need the support. It takes a village to help somebody out of an addiction. Let's move on. I'm not sure what's on the next slide. So outreach and engagement. So yeah, reach out in your community to facilitate. So establish communication channels with potential patients, with you know, consumers of whatever services, peer counselors. You want to establish contacts with agencies that offer, you know, various types of culturally responsive treatment and support. So for example, if I happen to be in Farmington right now, and I've worked in Gallup, and they're right on the edge of Navajo Nation. And so, you know, there's a real need to have liaisons between some of the hospital systems and treatment systems outside of Navajo Nation and then those within Navajo Nation, usually IHS. And sometimes it's difficult to work together and really communicate together, but it's really, really critical. Support syringe exchange for injecting drug users. And I think we have pretty good laws around that here in New Mexico. Advocate for improved access for homeless and other underserved populations. To a broader range of interventions. Yeah, you know, one of the biggest issues with treatment is transportation. Transportation and communication. So, you know, think about it. People who don't have a home often don't have a phone. They often don't have a vehicle. How are they going to get to treatment? I know some organizations are looking at outreach to really bring a team out to them. But again, it's really challenging. And I know in running Suboxone programs and working with you know, dozens of people at a time, you know, I've had quite a few patients who have difficulty adhering to a contract because they don't have a phone. And, you know, things like, you know, I might require on a contract, you know, if you relapse, I need to know. If you relapse, I want to know about it. You need to call so-and-so. Well, if they don't have a phone to call, or if they're missing appointments because they don't have transportation and they can't call to let me or somebody know that they're not coming in, then they're in violation of a contract. So we can't lose sight of really some of the basics that people need when they're stuck in this vicious cycle. Let's move on. Let's see what's next here. So key points. So yeah, we can help our patients to stay safe, even if they're not motivated or able to stop using drugs. It doesn't have to be black or white. Safer opioid prescribing and the use of the PMP programs is a way to decrease the supply of opioids, but do watch for signs of the street use, the IV drug use, because really a lot of our patients are crossing over. Syringe exchanges, needle exchanges, overdose prevention education for patients, for family members, for doctors and other prescribers. Naloxone prescribing are all ways of decreasing the harms and the risks to people who use drugs. And I think that maybe, is that it? I think we're down to the end here.